My name is Nicholas Tathatos. I'm one of the endocrinologists at MGH at Mass General. I work in the thyroid unit. And today is a session that is hopefully going to be interactive about some interesting and challenging thyroid cases. This is not supposed to be a lecture, so I would really, really appreciate if you participate. You can either make questions on the Q&A, or you can come on the microphone and ask me questions. I'm not supposed to be talking for 1 hour and 1.5 hours. You're supposed to be talking. So if anybody has any issues, doesn't have the questions that we're going to talk about, please let me know. Our tech support should be able to provide them to you. So I'm going to go ahead and start by reading the first question. And again, please feel free to jump in so we can make this an interactive session, okay? So let's talk about the first case. Our first case is a 74-year-old man who was started on amiodarone 3 years ago for the treatment of recurrent atrial fibrillation. He started function tests were normal prior to starting the therapy. And his current thyroid tests include a T4 that is slightly high. The reference ranges are listed at the bottom of the last question, so you can look at that if you need to look at the reference ranges. Free T4 is again a little high, T3 is high, and the TSH is fully suppressed. His thyroid gland is difficult to feel, and the question is, what's going on and how are we going to treat this patient? So any takers about what's going on with this patient? Well, obviously, he is hyperthyroid. Anybody care to suggest to make a comment about why this patient is hyperthyroid? Again, please try to participate. Otherwise, this makes no sense. Okay. I think everybody would agree that this is a case of amiodarone-induced hyperthyroidism. It's on the first line there that the patient was started on amiodarone. Okay, somebody has trouble opening that PDF. Let's give them a minute or so to make sure that they can access the questions. It seems it's a common problem. Okay, can we resend the questions? Yeah, our group doesn't seem to be able to access the questions. Is there any way we can try again? Send them again, please.
Sure. Do you want to email me that PDF and I can try to share it so people can have it?
Okay.
Have access to the Q&A. Can I just say they're under sessions on the lobby screen? Yeah, I just see one person that says, has the workshop started? I've answered that question. You're seeing where are you seeing people asking questions?
What is your email?
In the Q&A, but you can't see them because you're not.
My email is, sorry, A-Nugent, A-N-U-G-E-N-T.
And A-N-U-G.
E-N-T.
E-N-T.
At Fenway-group.com.
Fenway, I'm sorry, say Fenway what?
Fenway-group. I'm going to share it in the chat.
Group.com. Okay. I got it. I just sent it to you.
Great. I'm refreshing now.
Maybe if that doesn't work, I'll do what the other person said. I can share my screen with the questions on.
You could do that. Yeah, we could give that a shot. If you open up that screen, a new tab that has, or a new window that has the questions up, you could share that window.
All right. How about now? Can you guys see the questions now?
Yes. There you go.
Thank you.
You are very welcome. All right. Okay. Okay. So Again, I think if anybody wants to look at the reference ranges, if it's on the second page, let me know, and I can go to the second page of the layer right there. All right. Again, 74-year-old man with amiodarone for 3 years and who is hyperthyroid. Let me hold on. I need to open up the question section. There it is. Okay. So, anybody care to make any initial comments about what's going on and how we're going to manage this patient? All right. As I said, this is a amiodarone-induced hyperthyroidism. Before we discuss about what's going on with this case, can anybody care to comment about what changes are we supposed to see are expected and when somebody starts amiodarone without developing any kind of thyroid pathology? Are the thyroid function tests going to change or they're going to stay the same?
I think they're going to change because amiodarone can cause thyrotoxicosis.
Yeah,
So
I agree, but are there any changes without any disease? If the amiodarone doesn't cause any thyroid, do you expect any changes for the thyroid function test? The answer is yes. What you would expect to see in somebody who doesn't develop even any thyroid pathology is that the TSH will go up, the free T4 and total T4 will also go up, the T3 will go down a little bit, and the reverse T3 will go up. And they can even, the TSH can go up above normal, and the T4 and T3 can go up by like 20 to 40%, and the T3 can go down by about 30%. This is expected changes even if somebody doesn't develop any kind of pathology with a thyroid gland, just because of the nature of amiodarone, the molecule and the iodine content. And if somebody continues to do well without any pathology, after about 3 to 6 months, the TSH usually normalizes. The T4, the free T4 and the total T4 stay in that high normal to maybe a little high range, and the T3 stays in the low normal range. So expect to see changes when somebody is starting on amiodarone, but it's also critical to understand that if it is at all possible, try to get a set of thyroid function tests before starting amiodarone, the TSH, a free T4, and a total T3, so that you have a good baseline to compare it to. That's critical. Obviously, sometimes it's in the middle of a code or something that's not an option. But whenever you can, try to get a baseline set of thyroid function tests so that you have a good baseline to work with. So this patient became hyperthyroid. Can anybody care to comment how will that happen and what is the mechanism of the hyperthyroidism?
Well, there are two types of amiodarone-induced thyrotoxicosis. So usually type 1, there is increased production of T4 and T3.
Okay.
And this usually happens more in patients who have underlying disease, such as toxic multinodular goiter or Graves' disease that hasn't manifested. And type 2 is usually not increased production of the hormone. It's just that there is a destructive thyroiditis that leads to release of the hormone. Yeah.
Exactly. And what is the driver for type 1? The driver for type 1 is the iodine content of the amiodarone molecule. It's like pouring oil to the fire, basically. You dump a whole lot of iodine inside the thyroid gland, and the thyroid gland uses it to the predisposed thyroid gland, like you said, uses it to make more thyroid hormone. Now, what is a critical point here is that what determines what happens to the thyroid gland is actually the iodine content of the thyroid gland. If the thyroid gland is iodine deficient, it's much more likely that they will develop this type 1 amiodarone-induced hyperthyroidism, because the thyroid gland is iodine deficient. All of a sudden, we dump all of this iodine into the thyroid gland in the form of amiodarone, so the thyroid gland will take it and start making a lot of thyroid hormone. If the thyroid gland is iodine sufficient, that will not happen, and we'll talk about what happens in that case. So, what about the time frame? This person has been on amiodarone for 3 years. Does that tell you anything about what causes what is the cause of his hyperthyroidism? Whether it's type 1 or type 2. This thing happened 3 years after he started the amiodarone. Usually, type 1 hyperthyroidism happens early on in the first few weeks. It can happen later on, but usually it happens early on. Well, type 2 can happen at any point, even years after starting the amiodarone, potentially even after stopping it, because amiodarone molecule is very lipophilic, I'm sorry, and it can stay in the body for a very long time. So if something happens early on, you start to think more of type 1. If something happens later on, you start to think more of type 2. And I forgot to mention that in type 2, the actual mechanism is, we think it's a direct toxicity of the amiodarone molecule onto the thyrocyte. It's not the iodine content, it's that the molecule, the actual amiodarone molecule becomes toxic to is toxic to the thyroid cell. And of course, we have no way of knowing what thyroid glands are susceptible to that. So, okay, so how do we figure out if this is a type 1 or a type 2 iodine-induced hyperthyroidism? Any suggestions how we can figure it out, which one it is? Please remember that what I can see is the question and the Q&A session. I think there's another chat session that I cannot see right now. So if you have any questions and if you want to make your comments, please make sure you add them to the Q&A session, because that's the only one that I can see right now. So
we can do an ultrasound with Doppler flow, and if there is increased flow, then it'd be more likely that it's type 1 versus type 2 that's more destructive.
Yes, that is true. What is the one issue with the amiodarone induced hyperthyroidism in this case, though? The iodine content of the amiodarone molecule sometimes can blunt the flow of the thyroid gland. If you take a thyroid gland that has Graves not related to the amiodarone and give iodine, one of the very first things you're going to see is that this very rich blood flow, you won't be able to see it on the ultrasound anymore. So the point I'm trying to make is that if you see increased flow, it's definitely suggestive of type 1, but its absence cannot exactly exclude it. But that's a very good point. What else? What other tests can you use to figure this out? We said that if it's
stopping.
I'm sorry?
Would stopping the medication
okay
help?
That's how we manage it. Let's stick with the diagnosis first, and then we're gonna go to that. Do you think that stopping the molecule, the medicine, will help you figure out if it's type 1 or type 2?
Could it, like, if you stop it and if it's more like type 1, shouldn't it improve? Yeah, I don't know.
Unfortunately not, because amiodarone stays, like I said, it's very lipophilic, stays in the body for a very long time, particularly the iodine content can take up to a year to clear. So you won't be able to figure it out. And remember, type 2 can happen even after we stop the medication. So stopping the medicine itself is not going to help to distinguish one from the other. We said that type 1 is an overproductive state, something like Graves' disease, and type 2 is a destructive state. If you think about tests that we try to distinguish between the two, even in the absence of amiodarone, how would you distinguish one from the other? Think of basic thyroid physiology. How does the thyroid gland work?
Yeah, well, you can do the uptake scan, but wouldn't it be affected by the amiodarone?
What kind of scan are you talking about?
24-hour radio, like the radio iodine uptake?
Yes, the radioactive iodine uptake is the one test we use to distinguish a destructive process from an overproductive process. Again, because of all this iodine content, usually the thyroid gland is very saturated with iodine, and the scan is not very helpful. If you do a scan and you see uptake, you know it's a type 1. But most likely you won't see uptake because the thyroid gland is saturated, so the radioactive iodine will not be picked up, and you won't be able to make the diagnosis. There is another scan, another nuclear medicine scan, and that is, believe it or not, a sestamibi scan. There is some preliminary data to suggest that if you get a sestamibi scan, you might be able to distinguish the type 1 from the type 2. In the type 1, you're going to have uptake, in the type 2, you won't. but this has been studied in a very few number of cases, so it's hopefully we'll get more data soon. Another point that was made on the chat is the presence of antibodies, and the answer is absolutely. If you test for Graves' antibodies and they are positive, that's strongly suggestive of a type 1 process. Unfortunately, as you know, the absence of these antibodies doesn't exclude the diagnosis. It just, again, this is another test where if you have it, it helps, but if you don't have it, it doesn't help. Anything else? Any others?
What about inflammatory markers like CRP and ESR, which would be present in type 2?
Yes, inflammatory markers should be elevated in type 2, which is a destructive process, but absent in type 1. The problem with these markers is that the studies have shown that if you look at the graphs, although there are statistical differences between the two groups, there is such significant overlap that the clinical utility is very, very low. And you know, knowing like IL-6, for example, which is a marker that has been studied it has been studied a lot in this case, is more elevated in type 2. IL-6 can be elevated in so many different cases in the body that it's a very non-specific marker. And because of that significant overlap, even though it is quote unquote statistically significant, the actual clinical utility is very low. So long story short, distinguishing one from the other sometimes can be very, very difficult. Actually, most times can be very, very difficult, and it's hard to know which one it is. So how would you manage this patient? This patient is hyperthyroid, and we, you know, there's some flow in the thyroid gland. The thyroid gland looks on the ultrasound looks well, it has some flow. It's mildly, it's not particularly increased, and you don't have any. The antibodies are negative. How would you manage this patient? How would you what conclusion would you make, and how would you treat them? Can anybody make a definitive conclusion about whether it's type 1 or type 2 based on the information we have?
I think it seems more likely to be type 2, especially because his gland is so small. It would indicate that it's perhaps been destroyed.
I would agree with you. I would agree with you, and plus the fact that it's 3 years out after he started on I would agree with you. I would lean more towards a type 2, but can I tell you that for sure? No, I cannot. But yes, I would absolutely agree with you that this is most likely a type 2. All right, so how would you treat it? The question was brought up already. The first question the cardiologist will ask us, should we stop the amiodarone? It'd be great if you guys can vote on the chat. Give me yeses or nos. Would you stop the amiodarone, yes or no?
I don't think so, because it has such a long half-life. I think I would just treat the symptoms and consider starting steroids if need be.
I agree. The very simple answer to this is stopping the amiodarone is not going to help. It may actually make things worse initially because amiodarone blocks the conversion of T4 to T3, and which is why T4 goes up a little bit. And if you stop it, you may get more conversion of T4 to T3. So initially it may actually get worse. So the answer to the question is very simple. You don't have to stop the amiodarone. It's up to the cardiologist to decide based on the cardiac indications. It's not up to us to make that determination. If the cardiologist thinks the amiodarone helps, then they should stay on it. If the cardiologist wants to stop it for cardiac reasons, then they should stop it. It doesn't. We would not make that decision either way, because for us it won't make any difference. All right, so patient stays on amiodarone. How are we going to treat it? We think it's type 2 probably, but we're not exactly 100% sure. How are you going to treat it? Let's take type 1. How would you treat type 1, which is an overproductive state? How would you treat type 1 hyperthyroidism, amiodarone-induced hyperthyroidism?
With type 1, you're going to treat with methimazole, aren't you?
Exactly. Well, you would treat with antithyroid medications, absolutely. What's the characteristic of such a treatment? The characteristic is that it is resistant. This type of hyperthyroidism is resistant. You need higher doses for longer times to see the effect. If you take somebody with Graves' disease, non-amiodarone induced, and you put them on antithyroid medications, the majority of patients need low doses, 5 milligrams, 10 milligrams of methimazole, and they're going to respond, quickly. With amiodarone-induced hyperthyroidism, if it's type 1, you need higher doses. You need 20, 30, 40 milligrams of methimazole, and you need it for a longer time. You won't see a response until a month after the patient has been on amiodarone, on methimazole. So it's treatment that is resistant, and this type of hyperthyroidism is resistant to methimazole, so you need higher doses for a longer time. What about if it's type 2? How would you treat that?
Steroid.
Exactly. Steroids, and usually the dose that we start is something in the range of 0.5 to 1 milligrams of prednisone per kilogram per day. And what kind of response? Anybody care to guess what kind of response you should get? Usually you will see a response relatively quickly. You will see a response within the first couple of weeks. So I would say that it's if you start the steroids and you see a quick response, I mean, this type 2. But if you don't, then you have to think about the type 1. So how would you treat this patient? Would you treat them with steroid, or would you treat them with methimazole?
I would treat this patient with prednisone.
Okay. I would agree with you. I would definitely treat this patient with prednisone. In most cases, because distinction between type 1 and type 2 is not clear, depending on the severity of the patient, very often I end up treating with both.
Oh.
I put them on both methimazole and steroids, and I follow the patient clinically. If the patient is very minimal symptomatic, I would agree with you. I would just give them the steroids and follow them and see if they respond quickly. But if the patient is in the hospital, they're very tachycardic because of the uncontrolled AFib, and we need results quickly, I would actually put them on both and see how they respond. If they respond, if their hyperthyroidism resolves within the first couple of weeks, I would start tapering down the methimazole and continue the steroids. But if it doesn't respond in the first couple of weeks, I would actually start tapering the steroids down and continue with the methimazole.
Oh, interesting.
So it depends on the patient. The more severe the patient, the more likely I am to treat them with both. Unless, for example, if somebody does a scan and they have uptake in the scan, obviously I will treat them only with the methimazole. But that's highly unlikely. So this is the point I'm trying to make. Very commonly with amiodarone-induced hyperthyroidism, it's the distinction from one to the other is not clear. Sometimes there may be a little bit of both. So we end up treating both, and we see how the patient responds. If they respond quickly, we are saying we're making the assumption that they responded to the steroids, so we taper the methimazole. If they don't respond quickly within the first couple of weeks, we're saying that this is not a type 2. We need to keep going with the methimazole, and we start tapering the steroids. Any questions about this? What if the cardiologist comes in and says, you know what? I don't care what you do. I need this fixed ASAP. This patient is not going to do well until this hyperthyroidism goes away. How would you treat them? How would you treat them in that case? Well, in that case, no matter what the condition of the patient is, that's when you call your surgeon in. They were not going to like it, but there are some cases that have to be treated surgically. If it comes to choosing between the heart and the thyroid gland, obviously we choose the heart and we sacrifice the thyroid gland. So we have had cases in the ICU where the surgeons had to go in and do a thyroidectomy to remove thyroid hormone, to remove the thyroid gland, so that it doesn't play any role in his cardiac function, in the patient's cardiac function, and you're done. Certainly high-risk surgery. There are things you can do to lower in extreme cases, you can do things like charcoal chemoperfusion that will lower thyroid hormone levels in the short term so that patients can go to surgery with lower thyroid hormone levels in their blood. But that's something that is done very, very rarely. But usually the surgeons, an experienced surgeon with a good anesthesia team, can take these patients, take them to the operating room, take out the thyroid gland, and be done with it. So you don't have to worry about any treatments at all. You just allow for the thyroid hormone levels to start to come down. And once they start getting into the normal range, you put them on thyroid hormone and you're done. Very rare that has to happen, but it has to happen sometimes. I think I've done this maybe twice in my whole life. Now, any questions about amiodarone-induced hyperthyroidism? Now, if I were to ask you the following question, What is by far the most common abnormality you would see on a patient starting amiodarone? What would it be? By far, the most common thing that you see is hypothyroidism, not hyperthyroidism. Okay. And again, remember how we talked about the iodine content of the thyroid gland? If the thyroid gland is iodine sufficient, they're much more likely to develop hypothyroidism from amiodarone than hyper. If the iodine content is low, then it's much more likely that they will do it. It's not much more likely. The chances of hyperthyroidism increase. It's still more likely to develop hypo, but the chances of hyper increase. So the iodine content is very important. That's why it's important to know where you practice, what is the iodine, is the population iodine sufficient, deficient? It's very important to know that information. Okay, any questions about the amiodarone-induced hyperthyroidism before we go on to the next question?
Yeah, hello.
Yes.
How long must we steroids give in?
Usually you would see an improvement within the first 2 weeks. And then you would see an improvement in thyroid function within the first 2 weeks if you start at a dose of 0.5 to 1 milligrams per kilogram per day. And then I would continue the steroids for at least the first month and then start to taper them over the next 2 to 3 months and see if we can stop it. Any questions about this?
And is there a high risk for recurrence?
Usually it is possible, but usually the answer is no. These patients don't recur. No, particularly if it's a type 2, it usually doesn't return. It doesn't recur. I see another comment here about cholestyramine. You're absolutely correct. Cholestyramine is certainly a possible treatment. Cholestyramine, the way the cholestyramine works is that it binds thyroxine during the enterohepatic circulation. So you eliminate thyroxine through the gut, and it will help. It will lower thyroid hormone levels, but it's not very effective. It will have some effect, but it's a minor effect, and it can only be an additive treatment to that. It cannot be a primary treatment. All right. Any other questions about amiodarone? All right. So if it's okay, I'm going to go to the second question. 72-year-old man is scheduled for a carotid endarterectomy for critical stenosis of his right internal carotid artery. He had 2 TIAs in the past, but his preoperative evaluation reveals a free T4 that is low and a TSH that is 62. And the surgeon asks, should we go to surgery or should we postpone the surgery? It'd be great if you guys can vote yes to surgery or no to surgery. Just type in the text if you want. No takers at all? Anybody would send the patient to surgery the way they are now? It says, I got a comment that says, start levothyroxine and schedule surgery. Okay, would you postpone the surgery? If the surgery is scheduled for tomorrow, would you postpone it or not? Hold surgery, postpone? No, okay. Don't postpone. Okay, that's great. Why, if you want to postpone, why do you want to postpone? If you don't want to postpone, why would you not want to postpone? Can you make a comment on that? Because we have both opinions there. Let's take a step back. What are we afraid of? What can happen if somebody's hypothyroid and they go to surgery? Does anybody have any idea why is it bad to have surgery while a patient is hypothyroid?
Doesn't it increase your risk of complications, of cardiovascular complications?
Not cardiovascular so much. It increases the risk of more difficulty extubating from the surgery, acidosis, and potentially even more longer stays in the ICU. But those are in very severe cases of hypothyroidism. And the risk of dysrhythmias is that I see here. Again, I don't think surgery increases the risk of dysrhythmias in somebody who's hypothyroid. So the long story short is, again, we have to look at the patient. If the surgery is elective, if we have the option to postpone the surgery, then yes, surgery should be postponed. The patient should be started on levothyroxine, made euthyroid, and then go to surgery. That is obviously the safest way to go. But if the surgery cannot wait, and this patient is having TIAs, and the next one may not be a TIA, maybe a full-blown stroke, then it may not be a good idea to wait. So if the surgery cannot wait, if the surgery is presented as urgent, then you put the patient on thyroid hormone and they go to surgery. If the patient can afford to wait, then yes, ideally I would hold the surgery, make them be thyroid, and then go to surgery. In this case, I would certainly put them on thyroid hormone, maybe even start them on IV levothyroxine. I wouldn't load them, but I would start them on IV levothyroxine and then send them to surgery. If they need to go to surgery tomorrow, they go to surgery tomorrow. I would have a discussion with the anesthesiologist to be aware of the potential issues. I'm sure they know what those are in the setting of hypothyroidism. But I would not postpone the surgery and allow the patient to have another stroke. Any questions?
Should we give steroids?
Steroids will not help with the hypothyroidism, obviously. Steroids may help prevent conversion of T4 to T3. That may apply more in the setting of hyperthyroidism, not so much in the setting of hypothyroidism. It's not gonna add anything in the setting of hypothyroidism. It's not gonna make the patient more euthyroid any quicker, any faster. Risk of mixed edema, coma. I don't think anesthesia will increase the risk of mixed edema, coma. And this patient is up and talking to you and is obviously, somebody who's ambulatory. So, the concept of a mixed edema, coma is not in play here. And anesthesia will not increase that risk. Which form of thyroid hormone replacement is recommended in this situation? Oral IV is better. The question is, which form of thyroid hormone replacement is recommended in this situation, oral or IV? I think either is fine. If the patient is up and ambulatory and eating and drinking fine, I think oral is fine. Giving him 1 or 2 doses of IV levothyroxine is not going to make that much of a difference. I think if I did it, I would be treating more myself than the patient. But it's as long as the patient is in the hospital, in this case, I would treat him with IV levothyroxine. But otherwise, I don't think it would make much of a difference. If in an alternative case, if a hyperthyroid patient needed surgery, would you follow the same principle? The answer is yes, I would follow the same principle. There's a couple of additional things I can do if the patient is hyperthyroid. I can definitely put them on methimazole, which would help with thyroid hormone levels. Remember, methimazole blocks the production of thyroid hormone within hours. It won't clear the high levels in the blood within hours, but it blocks levothyroxine production in the thyroid gland within hours. I would put them on a beta blocker if they can tolerate it. And I would also consider using the steroids that were mentioned before, because they will help improve the clinical status by blocking conversion of T4 to T3. But yes, if the patient's surgery is urgent, like for example, the other patient with the amiodarone, I would, yes, they can go to surgery. I would do all of those things, talk to my anesthesia team, and the patient can go to surgery, yes. Any other questions? All right, so I'm going to go ahead with question number 3. A 32-year-old woman is referred from her psychiatrist because of abnormal thyroid function tests and increased anxiety. She has been on lithium for 4 months, and her pretreatment TSH is 1.8. She complains of palpitations, dyspnea, insomnia, and increased anxiety. Her T4 is a little elevated, free T4 is a little elevated, T3 is again a little high, and her TSH is fully suppressed. So the question is, What's going on? What is the diagnosis for this patient? Any takers about this?
I would assume that it's the lithium. I'm much more familiar with lithium causing hypothyroidism, so I don't actually know if it can cause hyperthyroidism.
Let's take a step back. What is by far the most common endocrine abnormality we see in case of lithium patients who have lithium?
Hypothyroidism.
Actually, the most common abnormality is a goiter, is an enlarged thyroid gland.
Okay.
The lithium, think of the lithium blocking the function of the thyroid gland. And when that happens, the thyroid gland doesn't make enough thyroid hormone. And as a result, the pituitary gland makes more TSH. And what does TSH do to a thyroid gland? It makes it grow so that it can make more TSH. And often enough, the thyroid gland can grow, develop the goiter, and make enough thyroid hormone to overcome the lithium blockade in thyroid function. But you're right, the second most common abnormality is hypothyroidism, because even though the goiter develops, it's not enough to overcome the blockade, and the patient does become hypothyroid on top of the goiter. But in this case, the patient became hyperthyroid. So the question is, what is the mechanism that lithium induces hyperthyroidism? Anybody, any takers, anybody have any idea? Lithium actually can be toxic to the thyroid gland the same way the amiodarone molecule can be toxic to the thyroid gland, and it can cause a destructive type of thyroiditis. So you would see thyroid hormone leaking out of the thyroid gland and causing a hyperthyroid picture like you see here. That is by far the most common form of lithium-induced hyperthyroidism. There have been some cases of Graves' disease associated with lithium therapy, and it's not exactly clear why that happens. These are patients that are obviously predisposed to developing an autoimmune issue, an autoimmune problem like Graves' disease, and somehow the lithium seems to trigger this and make this clinically evident. But by far the most common way lithium will cause a hyperthyroid case would be by a destructive process. So how would you make that diagnosis? How would you figure this one out in this case, whether it's a destructive process or an overproductive process? Somebody wrote about the Graves' antibodies. Absolutely. I would certainly check for the Graves' antibodies. If the Graves' antibodies are positive, you know you've got a Graves type patient. Unfortunately, again, the absence of these antibodies does not exclude the diagnosis. So we need another test. Let's say if the antibodies are radioactive iodine uptake. Absolutely. In this case, the thyroid gland is not saturated with iodine. So if you do a radioactive iodine uptake, you should be able to distinguish one from the other. Most likely you won't see any uptake, it's a type 2, but if you see uptake, you know it's a type 1. Yes, absolutely correct. All right, so we did the scan, the antibodies are negative, we did the scan, there's no uptake, so it's a destructive type. How would you treat it? Do you need to treat it, and how would you treat it? Again, actually, before we go into that, again, the psychiatrist asked you the same question. Do I need to stop the lithium for this? Would anybody tell the psychiatrist that they need to stop the lithium because the patient developed the hyperthyroidism? I got a no. And I would agree with you. I would tell the psychiatrist that it's again up to them to decide if lithium needs to be stopped, because this type of thyroiditis, this type of destructive thyroiditis is a self-limiting process. And in many, many cases, if not most cases, it actually doesn't even need to be treated. You can put the patient, maybe if they need it, on a beta blocker for symptomatic relief. But most of these cases are mild cases of hyperthyroidism, and they don't need to be treated. For this patient, because they have the symptoms, I would add a beta blocker and I would monitor them, but I don't think stopping the lithium is going to help in any way. If the process starts, it's going to continue and evolve the same way a thyroiditis process will evolve, whether lithium is present or not. The thyroid gland is going to release whatever hormone it's going to release, and over time that excess hormone will be metabolized and the thyroid gland will recover. So whether we stop the lithium or not doesn't make any difference, and all we can do is add the beta blocker to make the patient less symptomatic. Do I have a preferred beta blocker? It depends on the patient. The answer is I don't have a preferred beta blocker. If I think somebody's stable, I would try to put on a long-acting beta blocker so they don't have to take too many doses. if during the day, if it's a young woman who has low blood pressure, I may start on a short-acting beta blocker to see how she's going to tolerate it, and because I don't want to bottom down her blood pressure. So it depends on the person and the situation. And obviously, if somebody has asthma, that changes a lot, things like that. But I don't have a specific beta blocker that I prefer for all cases. Now, how likely is it for, do you give steroids? There's a question do you give steroids? The answer is no. I don't think steroids are going to help in any way in this case, because this is a very self-limited process and steroids have never been shown to be of any benefit. So I don't think steroids play a role here, no. I guess if somebody had a very severe case of hyperthyroidism, yes, I would consider it, but I've never seen that. So how likely is it, do you think, that this thing can happen again? Let's say the psychiatrist continues the amiodarone. How likely is it for the patient to have another episode? The answer is actually highly unlikely. Most patients, if they will develop this, they will only develop one episode and they will never develop another. It's actually the same thing like with subacute thyroiditis. So obviously you need to follow the thyroid function test, but usually these things recover and patients go back to normal thyroid function and they never have any more issues. Again, I will make the same point as I did with amiodarone. Our psychiatrists need to be vigilant and make sure they always check a good thyroid function, a set of thyroid function tests before starting the amiodarone, the lithium. I'm sorry. All right. Any questions before I go on to the next question about the lithium and the thyroid? Remember, the most common abnormality is a goiter, then hypothyroidism, and then some cases of hyperthyroidism. And in those cases, by far the most likely cause is a destructive process, not an overproductive process like Graves' disease. Okay, so I'm going to go on with question number 4. 35-year-old woman is referred to you because of an increasing fatigue and weight gain. A thyroid function test included T4 of 6, a FT4 of 1, a TSH of 4.3, and her thyroid gland is within normal limits on exam, but slightly firmer. Her TPO antibodies are weakly positive, and she informed me that she wishes to be treated with levothyroxine. So what do you tell her? And do you treat this woman, and how would you treat her, and why would you treat her, and what would you tell her? If there's a comment that says treat if planning for pregnancy. I would agree absolutely with you. May I ask why you say that? Well,
due to increase the risk of hypothyroidism during pregnancy.
Exactly, because she has TPO antibodies. I think just about everybody, all the experts would recommend, treating this woman with thyroid hormone, aim for a mid-normal TSH because she's planning pregnancy. But let's say she's not planning pregnancy. She's already had 3 kids and she's on birth control or has not signed another option, or she does not want to have any more kids. Would you treat her?
No. I believe that the current guidelines do not recommend treating based on positive antibodies alone.
Okay. Alison recommended that she would treat. May I ask why would you treat her, Alison? And what would be your goal for treatment? The question that Alison is bringing up, if we treat her, can we improve her symptoms? All the studies have shown that if you put the studies that I'm aware of have shown that if you take patients with these numbers and put them on thyroid hormone and bring their TSH down to 1, most likely they won't feel any better. What you commonly see is an improvement in symptoms for the first 6 months, and then they come back and tell you that the symptoms came back. So it's very hard to know what to make with these patients. The other comment that I would like to make is before I make any decision about whether I'm going to treat this woman or not, I'm actually going to repeat her thyroid function test. Very, very commonly, even in the setting of positive antibodies, if you check another TSH a week later, it's going to be 2.3. It's not going to be 4.3. It's going to be 2.8, 2.3, or 3.5. It's going to be lower. So always repeat these 2 or even 3 times before you actually start having a discussion with your patient about whether they need to be treated. And with these cases, to be honest with you, I pray that I will repeat the TSH and it will come back either as 2 or 2.5 or as 10, so that I have a clear path of what I'm supposed to do. But I'm praying, I'm hoping I won't get a TSH that is 4.5 in this case, a repeat one, because then you're going to have a very long, very difficult discussion with your patient. I don't think if you put this woman on thyroid hormone, you're going to help improve her symptoms. And I'm going to have that discussion with her and tell her that I don't think it's going to help. But this is the kind of patient that takes an hour in my office to have that discussion, and it takes a very long and very detailed discussion about how the thyroid gland works and how non-specific her symptoms are. But most of the time, I do not treat. I will admit to you that there have been a couple of cases that after that extensive discussion, we ended up de-treating these patients. But I don't remember a patient that came back long term and tell me that they actually felt better on thyroid hormone. Yes, you can fix the number. Did you make any? Did you help the patient in any way? I don't know that you did. And remember, this is a 35-year-old woman. For older folks, if you do that to somebody who's over 65, you may actually be increasing their cardiovascular risk. So I would certainly not do it in somebody who's over 65. For a younger patient, I would consider it. But for older patients, treating a TSH that is less than 7-ish may actually be increasing cardiovascular risk, not helping them. So I would not treat these patients. Any questions about these cases? Let me convert this case into something else. Let's say this is a 35-year-old woman who has these exact numbers with only one exception. Her antibodies are negative, and she wants to get pregnant. Who would treat her? Who would not treat her? Exact same numbers. Let's say she's asymptomatic. I don't want no symptoms, but she has these numbers. Her TPO antibodies are negative, and she's telling you that she's trying to get pregnant. Would anybody treat this woman?
I thought basically is the goal of TSH in first trimester is below 2.5, but I would repair the labs definitely, and then if still above 2.5, might treat.
The 2.5 has come from some studies. I think the most recent guidelines recommend that you either follow pregnancy-specific normal ranges, or if you don't have pregnancy-specific normal ranges, what you do is you aim for a TSH that is 0.5 less than the non-pregnant reference range. So I would certainly repeat the blood test in this case, at least once, to see what I get, and hope to get a TSH that is lower than that to put the patient at ease. But I don't feel there's no good evidence to suggest that treating these patients actually improves, has any benefit, improves either maternal or fetal outcomes or any kind of perinatal outcomes. So it's honestly, it's up to how you feel about it. I would agree that a lot of endocrinologists would actually treat because of the fear of what my hypothyroidism might do. One thing that I will tell you is that I would certainly follow this TSH very carefully every even 2 to 3 weeks in the first few weeks of the pregnancy to see how it evolves if I decide not to treat. But there's no clear indication that these patients actually do need to be treated.
Thank you.
All right. Any questions before we go on to the last case? Okay. So let's start with the first part of this question. A 36-year-old lawyer presents to you with a 2.2 centimeter right thyroid nodule. A biopsy is done, and a microfollicular lesion, also called follicular neoplasm, is detected. The patient is referred to surgery to have a right hemithyroidectomy. Before you read the next question, the following question: do you agree with the recommendation to have surgery? And if you agree, what kind of surgery would you recommend for to have? Let's say the other lobe, the left lobe, is completely clear. There's absolutely nothing there. Would anybody not recommend surgery? Would anybody recommend some other tests? Would anybody say go home and do nothing? Well, traditionally, before the era of molecular testing, a microfollicular lesion is what we call a Bethesda 4. It falls into the, we use the Bethesda classification system to for thyroid biopsies, and it has 6 classes. And this lesion would fall into Bethesda category 4, which is what we call the microfollicular lesion or follicular neoplasm. That category carries about a 20 to 40% risk of malignancy, depending on the institution. But the risk of cancer in nodule like this is about 20 to 40%. Before we had molecular tests available, there was only one thing we can do. We could take the patient to surgery. A biopsy would never give us the answer about whether this nodule is malignant or benign. Can anybody care to comment about why a biopsy would never give us the answer in this case, for a microfollicular lesion, if it is malignant or benign? In case of microfollicular lesions or follicular neoplasms, what the common diagnosis that we want to exclude is a follicular thyroid cancer, not a papillary thyroid cancer, a follicular thyroid cancer. I'm going to take a step back here to try to give you a brief reminder of the difference between the two. With the follicular, with a classical papillary thyroid cancer, what you see is very typical nuclear changes. And you see the formation of, this is you see it in cytologically for every cell, but you also see the formation of papillae when you have actual tissue to look at. However, when you look at a follicular thyroid cancer, there are no nuclear changes. When you take a follicular thyroid cancer cell next to a normal thyroid cancer cell, they practically look identical under the microscope. So the only way to know whether a nodule that is microfollicular, that has the potential of being a follicular carcinoma, the only way to know if it is a cancer or not is to see if there is vascular or capsular invasion, if the tumor has invaded into a blood vessel or has gone through the capsule. A biopsy, a fine needle aspiration biopsy, a cytological exam will never give you that answer. So I can do 100 biopsies on this nodule, 100 FNAs. I will never know if I'm looking at a benign follicular adenoma or a follicular carcinoma. So before the advent of molecular testing, we would, all of these cases would go straight to surgery. We would send them for what we call diagnostic thyroidectomies. It was the only thing that we can do to try to determine if this is a benign or a malignant tumor. However, nowadays, I see a comment here that says total thyroidectomy because of the size of the nodule. The size of the nodule, you're absolutely correct, is very, very important. A 2.2 centimeter nodule, believe it or not, is not that big. A 4, 5, 6 centimeter nodule is certainly a lot more concerning, much more likely to have a malignant phenotype, to be malignant. With a 2.2 centimeter nodule, I would actually feel comfortable doing a hemithyroidectomy. But having said that, if we decided to go down to the path of surgery, let's say molecular testing is not available where you practice, then I would have a discussion with the patient. I would tell them that I would be comfortable with a hemithyroidectomy because it is much more likely this thing is not malignant. This is benign, and even if it is malignant, given the size that it's only 2.2 centimeters. It is likely that it will not need further treatment with radioactive iodine, a completion surgery and radioactive iodine. So I would tell them to have, I would recommend they have a hemithyroidectomy, given that, if they take out half the thyroid gland, odds are in their favor that they're going to be fine, that there's no cancer. And even if it is cancer, they won't need any other treatment. And this is a young woman. This is a 36-year-old woman. If I can save her from having to take thyroid hormone for the rest of her life, for the next, 60 years of her life, I think that would be a good thing to do. I would tell her that there is a small chance, absolutely, there's a small chance that she may actually need to go back for another surgery to have a completion thyroidectomy and then get radioactive iodine. But the odds of that is significantly smaller than the odds of her needing absolutely nothing and going back to her life without any other further treatment. If this were a 5 or 6 centimeter tumor, I would agree with you. I would be having a very different discussion with her. So for those of you who practice in areas where molecular testing is not available, and unfortunately many countries don't have molecular testing available yet, the only option in that case would be for the patient to go to surgery. And in my view, I would do a hemithyroidectomy. There's a question about frozen section. Unfortunately, in cases of follicular thyroid cancer, frozen sections don't help. You're bringing up a very important point. In order to make the determination whether a follicular neoplasm is benign or malignant, you have to see if there's any evidence of, like I said, vascular invasion or capsular invasion. What that requires is the dissection and examination of the entire capsule of the nodule, which means creating many slides and sectioning the entire nodule itself to make sure that there is no capsular invasion anywhere or no vascular invasion anywhere. So a frozen section only takes a small piece and looks at it under the microscope. If you happen to see capsular and vascular invasion on that particular section, yes, you've made the diagnosis. But if you don't see it in a one single section, it doesn't mean it doesn't exist in any of the other parts of this nodule. So you cannot use it to exclude cancer. If you see the invasion, great, you made the diagnosis. But if there is no invasion, unfortunately, it doesn't help you exclude the cancer. Does that answer your question? And the other thing you need to know, when you look at pathology reports like this is critical. Sometimes you see the pathology report that says representative sections of the nodule and the capsule were taken. That pathology report is absolutely, unfortunately, it is useless to you. You need to call your pathologist and you need to tell them they need to section the entire capsule in order for you to know if you're actually dealing with a benign or a malignant nodule. And for a 2.2 centimeter nodule, the capsule is not that big. When you have a nodule that is 5, 6, 7, 8 centimeters, we are talking about making hundreds of slides of the entire capsule. But unfortunately, that is exactly what they have to do in order to make the determination if this is a benign or a malignant nodule. We are hoping that in the future, near future, molecular testing, looking at the molecular characteristics of a nodule will help us bypass this problem, but we're not there yet. But hopefully we will get there soon. But for now, remember your pathologist you have to make sure your pathologist sections the entire capsule, and ideally they should make that note in their path report that they did section the entire capsule. So let's say you have molecular testing, we do the molecular testing and the AFERMA classifier is reported as suspicious. For those of you not familiar with the AFERMA test, it's a molecular test that looks at hundreds of genes, and it's a good what we call a rule out test. If it comes back negative, then the risk of cancer drops to about 4%. But if it comes back suspicious, it doesn't prove cancer, the risk of cancer goes to about 50%. It doesn't go up about 50%. So now you have a molecular test that says that it is suspicious, so the risk of cancer is 50% in this nodule. Would anybody change how they would manage it? Would anybody say monitor? Would anybody say hemi? Would anybody say total thyroidectomy? Well, again, given the size and the fact that there's nothing on the other side, I would still recommend the patient undergoes a hemithyroidectomy. And I would, again, like I said, have the discussion with him. There is a small chance you may need another surgery, but most likely, even if this proves to be a cancer, she will not need any other treatment. So the patient has surgery, has a hemithyroidectomy, and this tumor is described as a minimally invasive follicular carcinoma with 2 foci of capsular invasion, but no vascular invasion. Is anybody concerned about this cancer? How aggressive do you think this cancer is? Do you think the patient needs any other treatment? So a follicular cancer is defined as minimally invasive. The traditional definition is the following: either only capsular invasion or capsular invasion and vascular invasion, but less than 4 blood vessels invaded. Studies have shown that above 4 blood vessels, the tumors tend to behave more aggressively, and they're called more invasive tumors. Now, this is not a strict dichotomy. There's no magical line that below 4 blood vessel invasion, less than 4 blood vessel invasions, tumors are benign, and above this, all of a sudden become more aggressive. When you go from 0 to 4 blood vessels, the more blood vessels, the more likely the tumor will be aggressive. So, that's why you have to take everything into context. And for example, a tumor that is 1 centimeter and has two blood vessels, two sites of invasion, I would treat differently versus a tumor that is 6 centimeters and has two blood vessels invaded. I would worry a lot more about the 6 centimeter tumor than the 1 or 2 centimeter tumor. So in this case, the fact that it only has capsular invasion, there's good studies that have shown that the risk of aggressive disease with only capsular invasion is as close to zero as you can get. So the risk of any aggressive behavior in this cancer is very low. So I would recommend the patient does not need any completion surgery. The patient does not need radioactive iodine, and they can just go back to their lives. Now, here's the question. What is the likelihood? Let's say she doesn't have any Hashimoto's and she has a perfectly healthy looking gland on the other side. What are the chances that she might need thyroid hormone versus that she doesn't need thyroid hormone? How do you think it's more likely that she will need thyroid hormone or that she will not need thyroid hormone? Low chance. No, I would agree with you. Chances are she will not need thyroid hormone. Chances are, I would say about 60% at least that she will not need to take thyroid hormone, but there's a good 30-40% chance she might. Now, obviously, again, 36-year-old woman, I would say that, for example, if she tells me that after her surgery that now it's time for her to have kids, I would most likely put her on thyroid hormone, because even if her TSH is, 2, a thyroid gland of a young woman who gets pregnant needs to make 30 to 50% more thyroid hormone, and she just lost 50% of her thyroid hormone production capacity. So if she tells me that she wants to have kids, I will most likely put her on thyroid hormone. But otherwise, if she's not interested in that, I would watch her and see how she does. And also, the point that I'm trying to make, the other point that I'm trying to make is this: the more I am worried about the tumor, the more likely I am to put her on thyroid hormone. Although I'm going to be blunt about this, there's very little evidence that this actually helps. Even if I recommend that, no surgery, no radioactive iodine, but I am a little uncomfortable for this tumor, I would like to keep her TSH low because, as you know, low, not suppressed, lower within the normal range. But again, this is most likely my own personal choice. I cannot tell you that there's good evidence about it, but I think the guidelines recommend against it. But I would, if this were a 5 or 6 centimeter tumor with this kind of characteristics, I would probably put the patient on thyroid hormone anyway, just to at least keep the TSH in the low, not to mid normal range. I wouldn't want the TSH to be 3 or 4 in this case. But again, this is my own personal choice, my own personal preference. I cannot tell you there's good data about this. So finally, several months later, she calls me that she's been tired, cannot focus, and her memory has been poor since surgery. And her TSH is, you put her on thyroid hormone, obviously, and her TSH is suppressed at 3 T4 and T4 a little high, and T3 is okay. What do you tell her? So we started her on 50 micrograms of levothyroxine, and her TSH is now suppressed, and 3 T4 and total T4 are high normal, and T3 is normal. But she says that she feels tired, she cannot focus, and her memory is poor. Would you increase the dose, decrease the dose? How would you explain it to her? I'm not sure what that note. Okay. So, Kathy would decrease the dose, and I would agree with you. But how are you? But she's going to tell you, doctor, I am going to feel even more tired. My memory is going to get worse. How are you going to treat that? Exactly. The comment Natalia wrote is that it is unlikely that it is related to her thyroid, and that's exactly what I'm going to try to explain to her. And I will also try to explain to her that keeping her TSH low may be okay because she's a 36-year-old woman, but if she stays with a low TSH, by the time she gets to 45 or 50, her bone density is going to have come down significantly, and she's going to be osteoporotic, and that's a really bad idea, and she may even go into atrial fibrillation at some point. So keeping her TSH low is not going to help. and it's not going to help with the fatigue or anything else. So I would definitely lower the dose of the levothyroxine. I absolutely agree with you. Okay, so guys, any questions about what we talked about? Any other thyroid questions you want to ask? Please, this is the time to have a discussion. Anything else you want to talk about that is thyroid related that I can help?
I want to ask about the prophylactic therapy before iodine contrast metal in patient with latent hyperthyroidism or TSH between 0.1 and 0.5.
I'm sorry. Repeat that one more time. You broke up a lot when you were saying that. I'm so sorry. Please repeat that.
Prophylactic therapy before iodine contrast metal.
Oh, if you want to give contrast and somebody has a low TSH.
Latent hyperthyroidism. Hyperthyroidism or
Listen, if the patient has a low TSH, even borderline low TSH, between 0.1 and 0.5, they deserve a workup for their hyperthyroidism, ideally before you give the contrast. They deserve to figure, they need a workup to try to figure out why they're hyperthyroid, and if necessary, treat this hyperthyroidism. Now, if they're going to get ideally, I would prefer to do that before the patient gets a contrast. But if somebody's in the emergency room and they have a low TSH and they need an urgent CAT scan, then they just get a CAT scan and you just follow the thyroid function test, very carefully, weekly, whatever you need to do to see if they change, and you put them on thyroid medication if the TSH is low. But if you have the choice of not getting the contrast until you figure out what's going on with the thyroid gland, for example, if you need to get a radioactive iodine scan, you want to do it before they get the contrast. If you have that option, yes, do that workup. If you don't have that option, just let them get the CAT scan because they need it, because it's necessary in the emergency room or something, and you just treat the hyperthyroidism blindly. You have to put them on methimazole, beta blockers, what you have to do, and you figure it out later. It's the best you can do. But ideally, if you have the option of assessing and treating first, you should do that if the TSH is low. So what are did I answer your question?
Okay, thank you.
Okay, there's a question. What are thyroid screening recommendations for asymptomatic women and men? I'm assuming you mean if there's somebody has no thyroid function, no thyroid abnormalities, just like when you screen for cholesterol, do you screen for thyroid? I'm assuming that is your question. If that's your question, that's an excellent question, and there is no one specific guideline. Some experts recommend nothing at all. Some experts recommend every 5 years for healthy adults, but there's no guideline. Obviously, I tend to choose the every 5 years, but I think I may be a little biased. But there's no specific guideline. Either nothing or every 5 years or so, but not more frequently than that. Okay, other workup options for suppressed TSH without biotin interference, negative antibodies, and normal. Okay, if the TSH is low, if the uptake, the radioactive iodine uptake is within the normal range, that's not a normal uptake. Be careful, if the TSH is suppressed, then the thyroid gland should have no iodine uptake. The thing that drives iodine into a thyroid gland is TSH. So if you take somebody who has no TSH, let's say if you take a mouse and you remove their pituitary gland and you give them an iodine, there will be very little uptake in their thyroid gland because there is no TSH to drive the iodine into the thyroid gland. So if you have uptake in the absence of TSH, it means something else is driving the thyroid, the iodine uptake, whether they have Graves antibodies that activate the TSH receptor, or they have an autonomous nodule or a multinodular goiter. Something else is driving the iodine. So in the setting of a normal TSH, in the setting of a suppressed TSH, but uptake on the scan, if there are no nodules, you just diagnose Graves' disease. Does that make sense? It's an abnormally normal uptake. Any other questions about anything? In the same case, what if Graves antibodies are negative? Again, even if the Graves antibodies are negative, but the TSH is suppressed and the scan, there's uptake on the scan, let's say normal ranges is 10 to 30%, and the uptake on the scan is 10% or even 8%, and there's no TSH around, the TSH is fully suppressed, and the Graves antibodies are negative, you just made the diagnosis of Graves disease. Because in the absence of TSH, the uptake should be 0. It shouldn't be 8%. Something, if there is 80% uptake, something is driving that uptake, and if there is no nodules to suggest a toxic goiter, then that's Graves disease. That's how we used to make the diagnosis of Graves disease before the development of these antibodies. If there is no TSH, there shouldn't be any uptake. If the patient with hyperthyroidism is pregnant less than 2 months, which medication would you give? Okay, that's a tough question. Excellent question, but tough question. So if somebody's less than 2 months pregnant and they're hyperthyroid, first of all, I would do my best not to treat them. I would only treat them if the hyperthyroidism is very, very severe. You know, if they have severe hyperemesis gravidarum and they throw up all the time and they're very sick, then yes, I would treat them. But if I can avoid it, I would actually avoid it. In Japan, what they've done, particularly for cases of Graves' disease, they've treated pregnant women with a tiny dose of iodine, non-radioactive iodine, like at 1 drop a day. And it has been shown to be quite effective, although the US guidelines recommend against it. The Japanese actually do this. So a tiny amount of non-radioactive iodine, of cold iodine, SSKI, or whatever your preparations are available to you, actually may be very helpful. If you have to choose antithyroid medications, the guidelines recommend using PTU, propylthiouracil, because of potentially less birth defects compared to methimazole. It is not 100% safe. We used to think that PTU does not cause birth defects, but it does. It may cause them less than methimazole, but it causes birth defects. And the current guidelines recommend that you use PTU in the first trimester, but after the first trimester, switch to methimazole because of less risk of liver damage. Is there any data for this? I am not aware of any data. This is purely expert opinion based on the fact that PTU may cause less birth defects than methimazole, but I'm not aware of any data that has actually proven that. So if you have to start something, I would say PTU would be the medication of choice, and then switch them to methimazole as per guidelines. Are you preventing any birth defects? It's extremely hard to know. There's no data to answer that question. But again, if you had to choose something, I would go with PTU, but I will make sure I tell the patient the black label warning about the potential liver problems. Is sick thyroid syndrome, should we give thyroid hormone or just wait? No, in euthyroid sick syndrome, we generally don't treat. It's the way the body responds, it's the way the thyroid gland responds to systemic stress. And we think it's an adaptive response, and it's not a maladaptive response, and it should not be treated. There are studies that have shown that treating with thyroid hormone may actually cause harm, not good. There is a school of thought that says it should be treated, particularly in very severe cases. I don't think that giving thyroid hormone in most cases actually helps, and it may actually do harm. So I would not treat euthyroid sick syndrome. Is there a correlation of the iodine uptake and the TSH level? For example, if TSH is only slightly low, do you still expect to be high in case of Graves' disease? Okay. Again, if the TSH is low, if there's uptake, that means that there's some kind of autonomy. Now, if the TSH is 0.5, that's a normal TSH. So if you have normal uptake, then that's a normal uptake. There's nothing to worry about it. But if the TSH is 0.1 and you have uptake, then that is strongly suggestive that the patient has Graves' disease. Is there a direct linear correlation between the two? No, I don't think so. I don't think there is. But the relationship is there. You know, if the lower the TSH, then less the uptake. There should be the lower the uptake should be if there's nothing else driving the iodine into the thyroid cell. You don't have to have a TSH, an uptake that is above the normal range. You don't have to have a TSH an uptake that is 40, 50, 60%. An uptake of 10 or 15% is enough to make the diagnosis. Does that answer your question? Anything else? Any other questions? A 37-year-old female, 32-week twin pregnancy with hyperthyroidism was refused treatment. Now asking about treatment in relationship to her twins. Okay. Can you specify why she's hyperthyroid? It's very important. The question I'm asking is extremely important. Does she have a toxic goiter or does she have Graves' disease? Okay. If she has Graves' disease, the first thing you need to worry about is the baby. If she has Graves' disease and her antibodies are positive, the Graves' antibodies cross the placenta and go to the babies. Will reach the twins. So fetal hyperthyroidism is the concern. So you have to monitor, you have to check the Graves-specific antibodies. And if the titers are high, you need to call the OB and you need to let them know that this is high-risk pregnancy for the complications of hyperthyroidism, goiters in the baby, small birth weight, high drops. So there's many complications. If the baby can become hyperthyroid and they can be really bad. So it's very important that the OB puts the patient on monitoring, frequent ultrasound monitoring, sometimes even weekly. And if there's any signs of thyrotoxicosis in the babies, then what needs to happen is that you need to treat mom with methimazole so that the babies can also be treated, because methimazole crosses the placenta so that you can treat the babies. And this applies, let's say you have a woman, this woman has had thyroidectomy, she has no thyroid gland, but her Graves' antibodies are positive and the babies show the evidence of hyperthyroidism. You give methimazole, we have to give methimazole to the mom. She doesn't have a thyroid gland, so methimazole won't do anything to her, but because we need to treat the babies. So that's one aspect of it. Obviously, if mom is severely hyperthyroid, then yes, she needs to be treated with methimazole. You know, it will lower if she's severely hyperthyroid, then she has increased risk of preeclampsia, you know, preterm labor, all those you know, complications, and she needs to be treated. But usually that happens with very severe cases of hyperthyroidism. Mild hyperthyroidism will not do that. Did I answer your question? Do you need any more clarification on that? While you answer, maternal fetal medicine monitor twins. Yes, absolutely. That's critical. The maternal fetal doctors have to monitor the babies very, very closely, particularly if they, like I said, particularly if the antibody titers are high. That's particularly important. Now, remember, in cases of hyperthyroidism, let's say Graves' disease, it tends to be a T3 dominant hyperthyroidism. So the maternal thyroid gland makes a lot more T3 than T4. What saves the babies is that T3 doesn't cross the placenta. T3 doesn't cross the placenta, only T4 crosses the placenta. So if mom has a lot of T3 in her blood, then this T3 doesn't go to the baby. So the babies, you know, there may be complications from mom being very hyperthyroid, but it's not such a concern for the babies becoming hyperthyroid because of the T3, of the excess amount of T3. But if the antibodies are present, then the babies can develop Graves' disease because of mom's antibodies. So these babies need to be followed very, very carefully with the maternal fetal doctors, and potentially get treated through mom if necessary. To be honest with you, this is very rare. I've never had to do it in my life. I hope I never do. But the books do describe that's certainly possible. So there's another question. Do we treat with selenium in women with positive antibody and normal TSH? I'm assuming you mean Graves' antibodies. There's the benefit with selenium has been shown in one study. patients with Graves' disease and Graves' ophthalmopathy. These patients received selenium to see if they can help improve the Graves' eye disease. And it did show that some patients did get benefit from the selenium as far as the Graves' eye disease when they were treated for 6 months or longer. The antibody titers did come down, but what you need to know is that it does work. You can use it. Particularly for women, there was a suggestion that we may be increasing the risk of diabetes with this treatment, and nobody knows why that is. But yes, for a short time, if you treat it for up to 6 months, you may have a benefit with Graves' eye disease. But there's no other benefit for hyperthyroidism itself, or if you have TPO antibodies from Hashimoto's. Even though the titers may go down of these antibodies with selenium, it does not mean that the disease will evolve any differently. There's absolutely, it may be the case, but there's just no evidence of that. We don't have any evidence of that. Again, Hashimoto's and want to be pregnant. There's no evidence that selenium will help in any way. The antibody titer may come down, but will it make her more fertile? Will it make her less likely to need thyroid hormone? No, we don't know that. I would treat the patient as if the selenium does nothing. It's certainly possible, but there's just no data about it. I would not depend on it as a mainstay of treatment, if that's what you're asking me. Can you comment on the... That is a most interesting question. Can you comment on the role of naltrexone for Hashimoto's? My friend, I cannot answer your question because I'd have to go look it up. I'm so sorry. I don't have an answer for you on that one. I'll make a note of that too. Naltrexone for Hashimoto's. I'm sorry. I would be happy to reach out to you somehow, but I have to look it up. I don't know. I'll tell you this, because of the comment you made to reduce TPO antibodies. Any process that my understanding is that there is no relationship between antibody titers and disease activity. You can have patients who have very, very minimal antibodies and very severe Hashimoto's, and you can have patients with sky-high antibodies and they remain euthyroid for the rest of their lives. So I don't know, there's no data to ever show that lowering the antibody titers actually helps. With Graves' disease, yes. With the activity for Graves' disease, yes, the antibody for Graves' disease, there is data to suggest that, for example, if somebody's been on methimazole for 2 years and their antibody titers disappear, and you stop the methimazole, you have a much higher chance of remaining euthyroid versus if you still have positive antibodies. But with TPO antibodies, I am not aware of any data that reducing the antibody titers actually does anything. Well, alternative medicine providers recommend a lot of things. And what I tell my patients is that these things have not been studied in a way that I would be comfortable with so that I can recommend them. So I cannot recommend for any of these. That's the answer I'm giving to my patients. Any other questions? Do you routinely recommend surgery for patients that have both Hashimoto's and Graves' antibody who go back and forth hyper and hypothyroidism? Okay, this is a very rare situation. It doesn't happen, it happens very rarely to go between hyper and hypothyroidism all the time. And in that case, you basically have two choices. One is the surgery, like you say, take out the thyroid gland, so this cannot happen anymore. Option number two is you put them on high dose of methimazole so that the thyroid gland cannot function no matter what happens, no matter what the antibodies do. And you add levothyroxine on top of that so that the patients are euthyroid. So you can manage this problem with either one of these. But yes, there are some patients who do need surgery if they don't want to take both medicines for a long time. So those are the two treatment options for these patients. But I've seen this maybe twice in my whole life, somebody going back and forth between hypo and hyperthyroidism. I've seen patients from hyper going to hypo and staying hypo a lot more often, but going back and forth, I've seen it very rarely, and I think it's a very rare event, but yes, surgery is certainly something that you can do. It's the same thing if somebody has multiple episodes of subacute thyroiditis, which is extremely rare. Usually people have one and they're done. But if somebody I've had a couple of patients who have like 3 or 4 episodes and they're fed up with it and they just say, just take it out so I'm done. Any other questions? Is there a high risk for miscarriage with levels of Hashimoto for Hashimoto? Not that I'm. The important factor here is that the TSH remains in the normal range. Patients who have Hashimoto's are described as having high risk of complications, pregnancy complications, period. But patients do better when their TSH is under much better control. So the answer here is make sure that the TSH is where it needs to be. And there's not much we can do about the antibodies, but in theory, yes, they may have increased risk of miscarriage, but there's not much we can do about that. All you can do is make sure that there's euthyroid as possible. Any other questions? All right. Well, thank you, everybody. And I hope you enjoy the rest of the conference.